Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today I'm talking to Ann Marie Goacher about the use of fluocinolone intravitreal implants for uveitis. Please, could you start by introducing yourself?
My name is Ann Marie Goacher. I am the head and neck and specialist uveitis pharmacist at the Royal Sussex County Hospital, and that's part of the University Hospital Sussex NHS Trust.
And can you give us a brief overview of your role, what your current job involves?
Yeah, so I look after the head and neck directorate. So that is made up of the ENT and maxillofacial surgery and ophthalmology departments. So generally, I support with anything drug related. So from individual patient queries to inputting into policies, guidelines, and pathways that involve drug administration. I do formulary applications and individual patient requests with the clinicians, and I get involved in education and training of colleagues. And I also have a specialist role within the eye hospital in the uveitis team.
Now, you recently presented a poster at the Clinical Pharmacy Show North describing the evaluation of the use of fluocinolone intravitreal implants for uveitis in a real world setting. And this is what I want to talk about today. But first, could you start by explaining what is uveitis?
Yeah, of course. So uveitis is an umbrella term for inflammation in the eye. So inflammation of the uvea, which is the middle layer of the eye. So patients can present with pain and photophobia, blurred vision, and floaters. They're the common kind of presentations. Now, uveitis can be caused by infections. So those would just be treated with antibiotics. So, inflammation caused by the infection. But it also can be an autoimmune disease where an overactive immune system is attacking the eye. So some patients will just have uveitis by itself, but other patients, it can be associated with other systemic autoimmune conditions such as rheumatoid arthritis or Crohn's and colitis, Behçet's disease, etc. And we do also have children with uveitis, and commonly it can go alongside the juvenile idiopathic arthritis that children can get. So they can commonly get uveitis also. So really the key is kind of control of inflammation in this condition. And there is, potential for vision loss from this inflammation and the damage that it causes. It can induce macular edema, which is leaky fluid in the eye, and if that fluid accumulates at the macula, which is responsible for your central vision, then it can impact your vision temporarily, but if left untreated, can lead to permanent vision loss.
And what is the normal treatment for uveitis?
So the treatment is dependent on what part of the eye is affected. So there's lots of subtypes of uveitis, but generally they're kind of grouped into what part of the eye is affected. So you can have anterior uveitis, which affects the front of the eye, and that's generally treated with steroid or anti-inflammatory drops. So a topical treatment. But then you have uveitis that affects the middle, so intermediate uveitis or posterior uveitis affecting the back of the eye. You can also get panuveitis, which affects the entire of the eye, but all needs to be treated. So the conditions affecting the front of the eye, again, would be topical. If you have anything affecting the middle or the back of the eye, the topical treatments don't tend to penetrate deep enough into the eye to really get control of that. So generally, in those cases, you would see patients moving on to systemic steroids would be the first line of treatment. If we can't control patients on systemic steroids, or really more importantly, the systemic steroids tend to work, but if you can't get patients off the steroids without them flaring back up with their uveitis, you would then move on to kind of secondary immunosuppressive medications. So commonly we'd use mycophenolate or azathioprine. And if then patients still can't be taken off those medications. So essentially, we're using them as steroid-sparing medications to try and get off the steroids because of the long-term effects of steroids, which we don't really want for patients. We do also have biologic treatment, such as adalimumab, which we can add in as a kind of a third line option for patients to get control of that inflammation. But really, patients who progress onto immunosuppressant treatment you'll have some patients, if the disease is in the front of the eye, they might just get a couple of episodes a year, which is treated with topical drops, and it goes away, and it might fizzle out, and they might get a couple of episodes in their life, and that's it. You may have recurring episodes for patients, but topical treatment is still enough. But for patients who progress onto that immunosuppressive level of treatment, you are talking about a number of years of treatment before you would have good enough control to maybe step back down off the treatment and to stop treatment. But usually it's years rather than months.
So was there an unmet need here? Where do the intravitreal implants fit in?
So insofar as what we spoke about with the fluocinolone implants and these long-acting steroid implants, and they are also an additional tool in our armory that we can treat these patients. So it's a local treatment in the eye. So it's very useful where we have patients where we really don't want to put them on any more oral or systemic steroids. So it has a local effect. And also for patients where they may already be on maximal treatment and they have had a recurrence of their macular edema or inflammation. So it's an additional tool. Or for patients who simply don't tolerate the required doses of the immunosuppression in order to get control. So again, if they're not tolerating or having too many side effects from the immunosuppression, we can use this as an additional kind of tool in our armory to get control of the inflammation.
Very interesting. Can you tell us a bit more about these intravitreal implants?
So they really are very, very tiny little implants. So they're like a little grain of rice. They are 3.5 millimeters long and 0.37 millimeters in diameter. So they're a tiny little grain of rice. And they are basically a long-acting fluocinolone implant. So they will be injected into the vitreous, so into the jelly part of the eye, and they will sit there and they will dissolve or elute the drug over time. And they can last up to 3 years. So they can stay in the eye and kind of elute the drug over about a 3-year period. And that allows us just to keep that steady control over that time of the inflammation. So really useful to have that kind of local treatment for the eyes.
Now I'm even more curious. How are the implants implanted? Can the patient feel them? And what happens after 3 years? Do you have to take it out?
So the patients have the implant done as an outpatient in the outpatient setting. So it's done at an outpatient appointment. They would come in and have the injection done. It can take maybe 10 to 20 minutes for the procedure. And they would have, some numbing drops to the eye, and the ILUVIEN would be injected and implanted, and then they would have some antibiotic drops to cover afterwards. But really, they don't feel the implant at all. It will just sit there in the back of the eye in the jelly. They don't feel it. So it's really quite remarkable. It's, it sits there and just then elutes the drug, but it will elute the drug over time, but the shell is made up like of a polymer that will just stay, the little shell will just stay in the eye.
This is fascinating. Now, can you tell us about your study? What did you do and what were the endpoints?
So the audit that we carried out of the ILUVIEN was basically us wanting to take a look at our subpopulation of uveitis patients where we had used this implant. The implant was licensed in 2019 and claims to give you 3 years of effect. So we wanted to see what was the real world data for this in our population of patients, and also having a look at other endpoints. So, time to treatment failure. So how long did patients get good effect from this treatment without requiring any other kind of rescue therapy? Was there an improvement in their visual acuity after we've used it? And what were the complication rates, etc.? I also, as a pharmacist, am interested in the drug, so I was interested to see if we could actually bring down the patient's other treatments on this by using this treatment. So were we able to reduce the doses of their systemic or topical treatments after we'd used the ILUVIEN?
And what were your findings?
So we had a look at all the patients who we'd given this to since we were able to use it in 2019. So we had 45 eyes in the audit from 34 patients, because some patients would have had it in both eyes. But 65% of those were female and 35% male. There was 32% of that population of patients who had an associated systemic other systemic inflammatory disease. So as I said, something in the rheumatology frame or something like that. And actually our findings were pretty positive. So in that population of patients, it did actually improve visual acuity in 58% of the patients. And then at the 6-month point, so 6 months after we've used the implant, 80% of the patients who had macular edema, it was resolved. So that's a pretty positive result. And then at 12 months, looking at the use of systemic treatments, 84% of the patients who were on systemic treatment, so not all of the patients in the population were taking systemic immunosuppression, but of those who were, 84% were able to reduce their treatment, and even in 3 patients were able to stop their systemic treatment. So that's a real positive for patients as well in reducing that burden of taking medications with that have side effects. And then even for patients on topical treatment, looking at all of the patients on topical treatment, there was a 20% reduction in patients who needed topical treatment. So again, a positive on that. Again, looking at the endpoint where, one of the major endpoints, which is time to treatment failure. So looking at, are we getting 3 years out of the implant? So we counted treatment failure as anyone who needed any additional interventions, such as, an increase in their drops, an increase in their other systemic treatment, or an additional shorter acting implant to control inflammation. And the average time to that treatment failure was about 15 months. So actually, that's not 3 years, of course, but it's not too bad considering that's over a year of stable condition where the patient doesn't have any inflammation flares. So that's really positive. But, the data, obviously one of the limitations of our data is that you take an audit as a snapshot of the data at one particular time point. So not all of the patients will have completed the 3 years of treatment. Some patients may have only even had it 6 months ago. So the data would be slightly skewed because of that, etc. And we did have a good amount of patients about a third of the patients in that population reached the 3-year point without any intervention. So that is actually quite positive.
That's very impressive. Were there any downsides, side effects of the treatment? And if so, how were they handled?
So the downsides really would be the known complications of using steroid treatment in patients. And that is that you are more than likely going to develop a cataract, and it will kind of speed up the time to which you'll develop that cataract. And then also a possibility that you will get pressure problems in the eye. So an increase in pressure in the eye can obviously lead to glaucoma. So that needs to be really monitored and watched for. So looking at those two, part of our study was looking at those endpoints as well. And we saw about 11% of patients who had intraocular pressure rises at about the 3-month mark. And three patients out of the 45 required surgery in the end to resolve this pressure rise, because glaucoma drops weren't enough to control the pressure. Now, pressure rises are common with steroid drops, like I say, and as long as you monitor for them and treat, the surgeries that we do for these pressure increases are relatively common. So you can treat by, doing cataract surgery, and you can treat by giving glaucoma drops, pressure lowering drops, and or if there's a need for surgery, that can be done and managed. So about 16% of patients developed a cataract post-ILUVIAN insertion. So, and the average time to cataract surgery after the implant was about 12 months. But also, I would caveat that with they've also probably had another shorter acting steroid implant before they've had the ILUVIAN, which would have contributed to the speeding up of the cataract formation. So both of those implants being steroid based would cause that effect. But these things are very manageable. Cataract surgery is one of the most common surgeries we do in ophthalmology, and is a very kind of bread and butter surgery. So if it's a choice between a potential of a cataract or ongoing uncontrolled inflammation, I'd have a cataract and a cataract surgery instead of having uncontrolled inflammation, just from the point of view of outcomes for the eye.
That's a useful way to look at it. What were your conclusions?
So ultimately, we felt that it was quite a positive outcome from using the implants, looking at it sort of objectively. It gave, significant benefits in managing inflammation, improving visual outcomes, and the opportunity to reduce systemic treatments. So all in all, very positive. And, like I said, as long as you manage the known possible outcomes with cataract and glaucoma, then you can achieve good outcomes using this treatment.
So where do you go from here? What are the next steps?
So I'm already actually reviewing the data again to address some of the limitations of the first audit. So looking at really looking at the population again, and maybe only including those patients who've had the implant 2 years or more, just to kind of give a bit more of a robustness to the data. And then also looking at refining the time points and the data collection. So putting a little bit more input at each time point, and having a bit more data, so that it sort of lines up, gives a more linear kind of comparison to the primary and secondary endpoints. So I'm actually in the middle of doing that at the moment. So we may have another version of it coming out with a little bit more detail.
Something to look forward to. Could you just clarify, is uveitis always bilateral?
So no, it's not always bilateral. For some patients, it does just affect one eye, but it can be both eyes as well. So it just depends, and it can just be one eye on its own.
Now, you are a very experienced ophthalmology pharmacist. How did you get into this field?
Really, it was by absolute chance, and falling into it is probably one of those things a lot of us experience in our careers. So really, I started when I got my job in the surgical team. And my team lead said, they just really wanted somebody to have a bit more oversight of ophthalmology. Now, at the time, that was mostly really related to their incredibly vast use of high cost drugs. So they use, for some other indications, we use a lot of anti-VEGF treatments, which are quite expensive. And so they wanted kind of pharmacy to have a bit more oversight. So that's kind of where I started. And then luckily the team at the Sussex Eye Hospital were so welcoming and supportive. I just continued to get involved in more aspects of the specialty, which before I started, I didn't have any idea about ophthalmology at all. I was really starting from scratch. And I never realized what a huge specialty it was and how many subspecialties were involved in it as well. So, but it is just really interesting because of that, because of all of the different aspects of it. And again, it is such a kind of emotive thing. At the end of the day, when you're dealing with these patients, it is, to do with their vision and potential loss of vision, which is a huge impact on patients. So, everything they do such amazing things and unbelievable treatments. And it's just really, really interesting. And so over the years, the more I've got involved, and we've managed to get more funding for me to be a bit more dedicated to that service. So it was between kind of luck and happy accident, but I'm really glad because it's become a real passion of mine.
And now, my last question. What would you say to a young pharmacist who was wondering whether to specialize in this field in ophthalmology?
I would just say absolutely go for it because it is such an interesting field with loads of amazing work going on. There's a real scope for pharmacy input as well. It may not be that obvious on the outset, but as soon as you scratch the surface, there's a lot to do in ophthalmology for pharmacy, and a lot of, working with colleagues and part of teams. So it is really interesting. And we also, for anyone who is thinking about it or has just started in ophthalmology, we have a growing network of ophthalmology pharmacy colleagues in the UK OPG, which is the UK Ophthalmic Pharmacy Group. And that's a real, brilliant for anyone who's starting out in the specialty that needs support. It's a group of ophthalmology colleagues there to give a helping hand or give some advice if needed.
Ann Marie Goacher, thank you very much for describing this fascinating project to us. That really has been most interesting. For more information about Ann Marie Goacher's work, please visit the website using the links in the description. And be sure to subscribe for more news, videos, journals, and podcasts. And thanks for watching.